Afternoon, everybody. Welcome to this week's report out. We'll just hang on another minute in case we've got other colleagues wanting to join us. We may have one or two. We've got two really good presentations to kind of pick up, one from pharmacy colleagues and then also then from rheumatology and medicines management. So I can see we've started recording, so that's great. Okay, well, let's get going then, because as I say, two great presentations to look forward to, and then gives us time for questions and answers. So, John, can we come to you for the stock and storage review?
Sure, yeah, no problem. Afternoon, everyone. Just to set the scene before we start here, as an ICU, just immediately prior to and during COVID, we found ourselves moving from pillar to post across seafloor where we reside, but eventually found our home on the LO607 where we currently reside. And once we found a home for ourselves, this is what basically set in motion a review of storage in many forms. So we'd already done changes to our general storage using the 5S system, but this basically was looking at reviewing stock levels of our pharmacy, and the areas where they were stored was also becoming a bottleneck, as you can see there in the photos, with having storage areas be immediately behind the nurses' station. We just found that footfall was just concentrated dramatically in one area. This meant it was difficult to assess access and both put away drugs, and that in turn had an impact on time and disturbance caused to others just sat at the nurses' station. So how does this link to the 7 Cs? Well, certainly finance, we believe that we could reduce waste and save money. In terms of team, we hope to improve access for staff while promoting a more efficient team and making for a better working environment. And then in terms of timeliness, ultimately getting drugs to patients in a faster way. So we got a pharmacy technician project lead involved, and we went through our stock list, and using a PDSA approach, drilled into that, and in fact, it drilled into both activities using that. Involved staff in assessment and review of storage, and because it was a practical problem, it lent itself really well to doing a Gemba walk to explore the storage options in particular. As you can see there, we utilize this spaghetti diagram. The nurses' station is always a hub for activity on wards, but we found that while people were going there naturally to use the phone, to use computers, having the drug cupboards there as well meant that people were backing onto each other in a very narrow and tight environment. So we felt it would be better to alter that. So in looking at our stock in particular, we found straight away, our pharmacy technician in particular found that we were making huge savings. There were items that were replicated. There were items that we were overstocked with. There were items that maybe we didn't use as much of, and we could narrow down our stock levels. And so once he'd seen how much we'd alter things, the analysis was spread out across the entire floor, involving all the ICUs. So you can see there in the itemization that we, as a general ICU, we cover LGO6, LGO7. So we made an instant massive saving. This allowed us to get a put-away service in place. So not alone would prior to this, pharmacy technician would deliver the drugs and then we would put them away, but we actually saved enough money to get a put-away service in place where the technicians were able to put the drugs away also. Yep. So we now have a sustained SWOT in place, and in fact a couple of months ago went through that again. Obviously the savings aren't going to be as great this year as they were previously, but it's still still enables us to home in on where we can concentrate and tailor our drug delivery to our patients. And that has altered slightly this year in that we don't use, for instance, epidurals as much, and we now use nerve blocks. So that's changed the drugs that we need to supply to support that. So there's better access for drugs for the patients, and it's easier to restock because we're not backing onto people sat at computers at the nurses' station. The environment at the nurses' station has now been reutilized and much better free flow of footfall. And we believe that this maybe could be replicated in quite a few areas, really, where storage of any description might be an issue. So what went well? Well, we're actually really surprised at the savings we made initially. And as I say, hence that why it was spread across the CSU. The put away service was a nice bonus. The nurses' station is less chaotic. And as you can see there now, we've now reutilized that space. Less interruptions at drug storage areas, and in particular for controlled drugs, where if you can keep interruptions to a minimum, it really makes it for a much safer environment. Reducing waste is now embedded, and we have a tailored provision of medication, as I've said, for patient use. So what would we do differently? Probably very little, because we'd learned a lot from our general supply revamp prior to that. So we had it, as we believed, well honed as what we had to do. We do plan to do similar now in relation to dressings and feed when we get around. Feed we've honed down well, but we still feel we could make improvements. Dressings, we have dressings, some come from supplies, some come from pharmacy, and I think collectively we could be saving a lot of money there as well. So that'll be next on the agenda. Our advice to others would be to promote innovation in your individual areas. And if you've got a physical problem, in particular with storage or bottlenecks, to physically and analytically walk through that practical challenge. And if possible, invite somebody from another area, because they'll have maybe a different perspective to you. You're there every day and may not see things that someone else will see from a different angle. And that is it. Thank you very much.
Fantastic, John. Really great piece of work. And I think the impact, not just for staff in terms of the frustrations and efficiency of their own day, but then the knock-on effect for patients and the benefit they get from that. And really love the kind of small scale, start small, go see what's going on, which is really wonderful improvement methodology, absolutely on the front line. So well done. Really great work. Thank you for that.
Thank you.
So, Well, I'm sure folk have got questions for John, but as we normally do, we'll go to MMPS and rheumatology colleagues, and then we'll take all our questions at the end. So I think Linda or Helen, are we coming to you?
Welcome to our Rapid Process Improvement Workshop Report Out around Imp-Rheum-Ving Homecare. Our process owners are Linda Bailey and Helen Lynch. Hello, my name is Sophie Williams, and I am a Sustainability Improvement Specialist and Workshop Lead for this RPIW. Leeds Teaching Hospitals spent £300 million in 2023 on medicines. Over half of that, £166 million, was spent on home care medicines. This service has grown by almost 50% since 2019. We focused on the biggest service of home care, rheumatology. It has 3,500 patients. At Chapel Allerton, the processes were outdated, and due to batching, we were creating bottlenecks for the patients. The team battling with this huge task are few in number and are constantly struggling with capacity and demand. The observations showed we have created physical barriers in the form of separate offices and even floors across the hospital. The prescription management team had to walk for around 5 minutes, 572 steps to be precise, to drop off prescriptions in pharmacy. So there's lots of opportunity for improvement. I'll hand you over to Wayne.
Hello, my name's Wayne. I'm a team leader for this RPIW, nurse by background. Takt time is a fundamental concept within the Leeds improvement method. representing the rate at which tasks must be completed to meet customer demand. It's determined by dividing the total time available for an operator to meet the demand rate. For the home care rheumatology process, the available time was 150 minutes per day, with a demand of 79 prescriptions by the home care providers being received. This results in a takt time of just 113 seconds for each operator within their cycle to complete their process. The target process report provides a detailed insight to the current performance and efficiencies of our specific process of rheumatology home care prescriptions. During the Rapid Process Improvement Week, we collectively agreed upon 11 metrics to be assessed while implementing our continuous improvement. The first metrics I'd like to discuss is the overall lead time, and that's from processing the prescription request to the prescription management team up to the point where prescription is completed and raised on our JAC system and ready to go to St James's for posting. The overall lead time for this process was 24 days. After discussing this with our sponsors, an ambitious target of 8 hours was set and agreed upon. The second metrics I'd like to discuss pertains to the work in progress, so the WIP. Prior to the RPIW, observations revealed 750 prescriptions were batched at various stages during this process. The team set out a target to achieve one piece flow, and we'll discuss that in later in the slide deck. Other metrics agreed upon during the week included a 5S assessment of the home care hub, which again will be discussed in the slide deck in a few slides' time, staff satisfaction, and a sustainability measure related to patient interactions. And I'll pass over to Linda.
Hello, my name is Linda Bailey and I am the lead nurse for rheumatology. This week I have been a process owner for the RPIW. This is our value stream map demonstrating our current state of managing routine home care prescriptions. Our current lead time of the process is 583 hours, or equivalent to 24 days. As Wayne has mentioned, our ambitious target lead time is 8 hours. Leading up to the RPIW, the KPO team visited home team members and observed and timed the current process. The actual touch time, processing time observed was 13 minutes and 50 seconds. These outcomes enabled us to identify the current wait times and come up with ideas of how to initially reduce the wait states and by the end of 90 days, hopefully remove them altogether. We initially came up as a team with 50 ideas looking at our mental valleys of this process. We agreed one of our shifts should be moving from analogue to digital solutions. It was in our gift to explore how we could implement our ideas using the current systems we have within the trust. Therefore, our first PDSA was to focus on digital. This would contribute to using less paper and providing sustainability. Claire is going to run through the test of change using the current system used in pharmacy to support a continuous flow within the process and help reduce wait times for patient queries.
Hello, my name is Claire Driffield. I'm a senior pharmacy services assistant and I've been a team member in this RPIW. As a team, we've looked into using the existing prescription tracker to cut the time spent to resolve queries. The tracker is a mechanism we have to enable people to see where in the process a prescription is. Previously, the prescription management team had to phone or email pharmacy with any queries regarding prescriptions. They would then have to wait for a pharmacy member of staff to get back to them, which would depend on the work that was already in pharmacy. The PDSA showed that having access to the prescription tracker enabled the prescription management team to see where in the process a prescription was without having to wait. This massively reduced the time taken to resolve queries. I'll now hand over to Helen.
Thanks, Claire. Hello, my name is Helen Lynch. I'm the pharmacist validating the majority of the home care prescriptions coming through Chapel Allerton each month, and I'm a process owner for this week. One of the top 2 ideas in the RPIW is the Home Care Hub. This allows all the teams involved in the prescription journey to work collaboratively in a defined area to produce one piece continuous flow. The hub idea had been conceived some years previously by the 2 of the team members here today, Linda and Dawn. This RPIW seemed an ideal opportunity to test the hub with collaborative working. Prior to this, the RPIW, the cycle time was 13 minutes 50 seconds with all the teams in separate areas. In the hub, using continuous flow, The cycle time is reduced to 9 minutes 31 seconds. This collaborative way of working has proved to be successful, but to continue this manner of working, we will need consistency in our staffing and equipment, which requires leadership support. To quote Donna and Angela in the prescription management team, it's a lot easier than ringing pharmacy. And I'll hand over to Jason.
Thank you, Helen. Hello, my name is Jason Ward, and part of my CNS role is to prescribe home care medications. I was an RPIW team member this week. The most extensive lead time wait state is the 336 hours that is built in between receipt of the email request from the home care company and the prescribing of the drug. This exists to allow time for the patients that are yet to have their bloods taken to be contacted and encouraged to do so. Available and up-to-date blood results are essential to ensure medications are used safely and effectively. Currently, the prescription management team will post out a letter informing patients that they require a blood test and that these have been ordered via the ICE system. It can take up to 2 weeks for patients to receive a letter.
Hello, my name is Kirsty Blake-Morash and I am the KPO service manager and a member of the away team this week. One of the benefits of the RPIW is how with varying experience and knowledge can allow ideas to be generated and make way for innovation. The focus of the ideas to solve the blood issues was how we could reduce time and move from a reactive process to a proactive one. 2 main ideas were discussed. The first being identifying our patients and notifying them when their blood test was due and not overdue. And secondly, contacting our patients via text message instead of sending a letter.
Thank you, Kirsty. My name is Sumra Shafiq and I'm one of the neurosciences pharmacists at the LGI. Of all the patients we spoke to, they all preferred the text messaging service. They felt the messaging service was a cheaper option for the NHS, and it would also help the environment by saving on paper, which is obviously one of the 7 Trust commitments around sustainability. They also felt that this would also have a reduction in the anticipated lead time, as Jason alluded to earlier, which would reduce it from 4 weeks to 2 weeks. We use the envoy messenger system, but we're hoping this is an interim, and we will hopefully use WhatsApp as an interactive portal to allow patients to have a bigger role in requesting their bloods and prescriptions. But we should caveat this with that text messages are not suitable for all our patients, such as those that are outside of the Leeds area, those that might have health literacy needs. So our current process that includes the sending out of letters will continue to have a role, but we're hopeful that the number of patients needing that will be lower than current. Hand you over to Kerry.
Thank you, Sumra. Hello, my name is Kerry Parry. I'm a pharmacy associate lead clinician for clinical services, and I was a team member this week. Our team agreement begins with the acknowledgement that MDT working in the hub means each person has their own role and associated responsibilities. Simply by co-locating in a way that doesn't currently exist naturally opens a network of support. Key tasks have been identified for the start and end of the day to provide a framework for standard working practices with respectful behaviours underpinning it all. There will be regular review of the tasks themselves and any issues arising. Each team member will contribute to ongoing review and day-to-day running of the hub. The spirit of collaboration, which began in earnest this week through the RPIW process, will continue and will help address the expected anxieties and concerns relating to change. Maslow's hierarchy of needs reminds us that we must get the fundamentals right with individuals' physiological and safety needs to lay the foundation for a sense of belonging and connection. This directly informed how we set up the hub to enable staff to achieve their full potential and introduce these improvement changes successfully. I'll hand you over to Penny.
Thank you. Hello everyone, my name is Penny Chu and I'm the Deputy Lead Clinician for Medicine Supply and Procurement, and I have been a team member in this RPIW week. Having implemented the 4 PDSA cycles multiple times this week, we were able to reduce our in-house prescription process to being a 6-step process from our initial 7 steps. Wait stays in between each of these steps were also dramatically reduced in the whole process, from an initial lead time of 24 days down to just over 9 minutes in our full process simulation. There are some caveats to this reduction, and these include not taking into account prescription requests from home care providers over a weekend, as this is completely outside of our direct control. And secondly, assuming every role required in the in-house prescription process are available in the same hub space at the same time. And we have drawn up team agreements to support with this, and this will be adhered to by the whole team. Ultimately, we were able to achieve this improvement by focusing on using one piece flow and not batching prescriptions. We're confident that this will be the continuous improvement stemming from these PDSA cycles going forward. I'll hand you back over to Wayne.
Thanks, Penny. So following the PDSAs, I'll summarise the impact that has on our metrics. So first one, as has been alluded to throughout the presentation, our overall lead time has gone from 24 days to just 9 minutes, with the caveats that Penny has mentioned previously. The work in progress and the batching of prescriptions prior has been banished, and we've moved to a one-piece flow, which has successfully been implemented across the week. The 5S assessment of the hub identified areas needing additional support, and these have been raised and escalated to the relevant people. And as mentioned, we've got our respectful behaviours and our team agreement in place. The implementation of the text messaging system has significantly reduced the use of paper, so that's sustainability measure number 11, and that's relating to cost savings and CO2 savings from not sending letters manually, so financial savings and CO2 as mentioned. And finally, patient satisfaction pre-RPIW was monitored via day text reports and PALs, and although we didn't get a overall perception of the home care service from a patient perspective, when we contacted patients relating to the digitalisation of reminders, it was well received. I'll hand over to Tony.
Hello, my name's Tony, and I'm a quality improvement partner with the Trust. This week, I've been an away team member on this RPIW. The challenge facing the team has been a microcosm of that which confronts the organisation and the National Health Service as a whole. The shifts required to achieve the desired transformation must promote engagement, particularly of patients. They include migrations from hospital to home, from treatment to prevention, from analogue to digital. Successfully developed, the new future state will be patient-led and more proactive, with patients empowered to be more actively engaged in their own healthcare.
Thanks, Tony. So our key learning this week, we wanted to invite informatics support in as part of the RPIW or our advisory group, but we realised this a little bit too late. So I think in light of what Tony's just said, it might be learning for the KPO team to take this forward as a recommendation in every event that we have going forward. We also learned that we need to be clear on our actions coming out of the rapid test of change during the week, because in our enthusiasm, we were duplicating some of the requests sent out to colleagues. We need to ensure we have a suitable room for a learning and caring environment for our team, and we had to shift around this week in the warm rooms of Chapel Allerton. And then I just want to say that I feel such a privilege to have worked alongside this wonderful team this week. They've honestly been so open-minded and embraced every challenge. Walking in each other's shoes has set them up for ongoing collaboration and compassion. Thank you, Team Dazzlers and Hubsters, which are team names. We even had theme tunes this week, so thank you so much. And then finally, thank you to those additional team members that either couldn't be here or are around doing their work this week today. Thank you. And to those in the home team and Chapel Allerton for housing us and keeping us fed and watered. And what all this is about, obviously, is our rheumatology patients. So thank you to them and those that interacted with us this week. Thank you very much.
Fantastic. So great, really wonderful, really broad, big team performance there. Well done to the whole team, and well done for that great report out. Really inspiring work. And again, you know, that common theme of actually working right at the front line to improve delivery of services to patients, really encouraging to see, and wonderful team participation as well. So let's open it out for questions for either of our presentations, either for John or for the rheumatology team and MMPS team. So Jenny.
So my question's for John, because I'm still processing what that RPIW has just managed to achieve. So I think that was phenomenal. But John, what I was really impressed by your work was the thoughtfulness with which you'd chosen the right LIM approach to the problem you were trying to solve. And I just wondered did that come naturally, or did you have to do some work up front in order to be able to say, this is what we're trying to solve here, and therefore which bit of our method helps us do that?
Yeah, like the spider diagrams in particular, like it looks simple on paper, but that was a real insight, to be honest, because it really helps you track that footfall that is concentrated in one area. And if it wasn't for the LIM process, we wouldn't have really been aware of that as such. Other processes like the 5S we'd used before, all right, and we knew that we could adapt that to our pharmacy problem as well. But yeah, and the Gemba walk, of course, as well. But once you learn these processes, you know, you almost do them without thinking. And I know Jimmy in particular, when we're working on this through LIM, talked about you know, walking in someone else's shoes. And as I say, if you get somebody else in to have a look at a physical problem you have in terms of, you know, bottlenecks, etc., because you're in that environment every day, you may not see the wood for the trees, as it were. And whereas simply somebody else coming in and having a look at it with you really helps.
Great.
Great work, well done.
Thanks, John. Any other comments or questions? Andy?
Yeah, just a comment. Hopefully you can you hear me? Because I've turned my headphones off. Yeah, you can. Fantastic. I'm sat with Laura Wokes, our head of nursing here. I'm just amazed by both of these pieces of improvement work. And the telling thing for me here, and Phil, we've talked about this quite a bit in various meetings about the need for CSUs to work together to make improvements right across everything that we're doing, and that comes across so loud and powerful in both of these pieces of work. And also using, John, you just articulated really nicely about the LIM, the various improvement pieces of work that you've done to get to your outcome, and similarly using the RPIW when you get passionate frontline staff together, it just shows what you can do actually in terms of creating the time and the space. So fantastic work, both report outs, and let's keep that collaboration between CSUs because that's really important. So well done, guys.
Thanks, Andy. You make a really important point that opportunity of, and I think keeping our patient-centered value is actually the key to a lot of this. I think here is what's best for the patient and how do we use our combined teams to do that work. But yeah, absolutely brilliant. Anyone else wanting to come in or raise a question, make a comment? Jenny?
Sorry, wrong hand.
Oh, you're waving.
Yeah,
waving.
no, I will wave. No, it is a hand. It is a hand. John, I just wondered, you talked about the scale up and the scale up and spread opportunity. So is that something that you're thinking about? Just help me understand how big that opportunity is.
The scale up and what we did in terms of so we basically that got spread across all three ICU disciplines here at LGI, and that's St James J81, J54, J53 as well. So it was all encompassing really, and certainly because it was new, it made tremendous savings in that first year really, immense. Like from now on, it'll be a case of it'll be minor savings, but certainly tailoring drug delivery towards patient need. Because when we look through the brilliant thing about the stock list is when we look through them, we can see what our usage has been previously and if it's gone up or down, and we can tailor it accordingly. And as I say, nothing stays static. and like I mentioned earlier on, we don't use epidurals now as much, so that's made savings in and of itself. But we now use nerve blocks, and it's much better for the patients, much better pain control. And then we've altered what we hold on the shelf then to treat that in terms of medication. So it's just having the process in place doesn't always reap, won't always reap monetary return, but it will always reap return for patients and staff.
Thank you, John. Claire?
As for the Chapel Alton RPIW, I suppose what I'm keen to understand from you is, did you enjoy it? Yeah.
Yes, lots of laughs, lots of mention, lots of work, but together it's been great.
Were you surprised by where you got to by the end of the week? Because some of those shifts are, are significant. Were you surprised?
Yes.
Yeah.
We reviewed, Claire, the fears and expectations just before we came on to report out, and some of the expectations we've exceeded, I think, is what you said. But the fears have been that there might not be any improvements has certainly been smashed. So really great teamwork.
Brilliant. It's great work, guys. I'm a bit like Jenny. I'm still trying to process some of what you were saying through there, because there was a lot, but it's really, really great what you've achieved there. Thank you.
Thanks, Claire. Jimmy?
Mindful of time, obviously kind of really proud of everything I've heard here, the application of the method. There's so much to go after. We could fill half an hour, so I'll just say thank you to everyone involved. I think Claire's question to close is brilliant, because we know that people do their best work when they're enjoying it. So great to hear that that's the case. And John, I know from working with you that not necessarily fun, but certainly seeing you and the team benefiting from that, it's a great way to share. So yeah, thanks to everyone. I'll leave it there.
Great, thanks, Jimmy. So look, we are at time. Thank you very much. We've got John on one side, and then I think I've got Sophie, Wayne, Linda, Helen, Claire, Dawn, Jason, Kirsty, Sarah, Kerry, Penny, and Tony. So apologise if I've missed anybody else out of the MMPS rheumatology team. But two brilliant presentations, really great application of the method. Great to see the real kind of detail of the method in there, because it's always heartening to actually do Leeds improvement work rather than saying we're taking that approach. Really great patient-centered work, hopefully, as we've discussed, enjoyable for staff, but actually making staff's working lives better, which actually gives us a big impact in how we can deliver better quality care to our patients. So fantastic, well done everybody, and we'll bring Report Out to an end there. Thanks, see you next time.